at the end of lecture, you should be able to explain the classification and the etiology of Class 2 Division 1 and the Division 2 malocclusion. Then you should be able to discuss the criteria for the patient assessment and dependent treatment planning for Class 2 Division 1 and Division 2. Then you explain the clinical features of Class 2 Division 1 and Division 2 again. Explain the treatment planning for the Class 2 Division 1 and Division 2. And with a special emphasis on the reduction of overbite in the Class 2 Division 2. So this Division 1, Division 2, they can be quite different in the treatment plan, but they have similarity also. So Class 2 Division 2, mainly they have this what we call severe overbite. It means the overlapping between the top and bottom teeth is more than average. So sometimes it can be deep and traumatic bite. So the content both will be the same. Those of part 1 will go through the Class 2 Division 1, then the part 2 will go through Division 2. So then the lecture content will be introduction, etiology, occlusion features, patient assessment, and finally how we plan the treatment together. So the introduction, Class 2 malocclusions, then usually people complain of vanity, or it can be a goofy teeth. Goofy is a character of this Disney cartoon, then usually have the top upper incisor sticking up. So this causes an aesthetic concern, then usually people will be teasing quite badly. Then they can be rough by their friends, then it cause a lot of social disturbance. So they have a difficulty in chewing the lip seal. So if there are two sticking out, the upper teeth, then the lower lip cannot cover the top teeth. Then I might have difficulty in bringing the bottom lip to the top lip together, which causes the lip incompetence. So if you look at the people who have lip competency problem, then usually have Class 2 Division 1, which means the upper incisor is sticking out too much. And they also have this increased risk of trauma. So whatever sticking out, so if you hit on something, the wall or instruments or baseball pack, then usually they will hit on the front incisor first, which means they're risking the front incisor for trauma. So Class 2 Division 2 patient, if you look carefully, most of them have the chip incisor. That's because of the sport or when they are playing with the friends, then they easily hit on the front incisor. So we pay attention. So sometimes if they hit the incisor too badly, then can cross the crack line or sometimes the non-vital incisor. If you're not careful, you miss out this, then you fail the exam or it causes negligence. So according to angle classifications, so it's a distal relationship of the mandible to maxilla, which is purely based on the molar relationship of the first permanent molar. So angle classify everything according to molar relationship. So you look at the molar, the first molar. If the mesial buccal cups of the maxillary first molar occlude mesially to the mesial buccal groove surface of the mandibular first molar, then consider Class 2. So for this picture, you can see the molar, upper first molar, then occlude anterior to the mesial buccal groove of the lower first molar, which is a Class 2 molar or Class 2 angle classification. So angle classify the malocclusion based on the molar relationship. So you can see if you want to go through some revisions, then the top left pictures, can you see the cursor? Yeah. Can you see my slide?
Yes.
Yeah, okay, all right, okay. So the top left is a Class 1. Okay, basically it means the upper mesial buccal cups occlude on the lower molar on the mesial buccal groove, exactly on that. Then if you talk about Class 2, which means the mesial buccal cup occlude anterior to the mesial buccal groove of the lower first molar. If a Class 3, it means the opposite, behind. So even though they're Class 1, it can cause a malocclusion, which means crowding of the upper and lower jaw. So incisor classification is according to this British Standard Institute. And they classify the malocclusion based on the incisor relationship. So they look at this cingulate plateau, which is the middle third of the upper incisor palatal surface. Look at this black shadow on top. Then if there are lower incisor occlude on this black shadow or the cingulate plateau, then they consider Class 1. If behind this cingulate plateau, then they consider Class 2. Then this Class 2 is subdivide into Division 1, which is upper incisor procline, and Division 2, which is upper incisor retrocline. Then if a class 3, then it's just reverse. The lower incisor occlude anterior or at the front of the cingulate plateau. So British Standard Institute classification, like I said before, is only on incisor. Division 1 means the upper incisor procline or average inclination with the increased overjet. So this is a classic example, the lower lip is trapped behind upper incisor, which means the lip incompetent. Then class 2 division 2, it means upper incisor, the retrocline with minimum or no overjet. So class 2 division 2, usually the upper incisor retrocline, they're pushing back. That's why they have a minimal overjet issue, but they have a deep overbite issue because the incisor retrocline, which means the bite deeper. So this ventral linden, then they further classify the class 2 division 2 into these 3 types. But it's not very commonly used, this classification. So it classifies the severity of the class 2 division 2. It's subdivided into type A, type B, and type C. So type A means the lower lip, the upper incisor and lateral incisor are retrocline. They're less severe in nature. It means the lower lip then cover the top 4 front teeth, and that's why they are not that severe class 2 skeletal pattern. And compared to class B, type B, the central incisor are retrocline and overlapped by the lateral incisor. So usually this one is more class 2. That means the upper lip only can cover the top front 2 incisors, central incisor, not the lateral incisor. So I have a step between the central incisor and lateral incisor. And the type C means the lip can cover all the 4 front incisor, and they are more class 2 than the central incisor, lateral incisor, retrocline, and overlapped by the canine. You see there's a step between the lateral incisor and the canine. So these are usually the more severe class 2. Okay, so look at the picture. The type A just means the 4 front incisor leaning back, and the type B means the central incisor leaning backward, then the lateral incisor is still normal inclination, and the type C means the 4 incisor they're leaning back, then plus the crowding at the canine area. So the canine pushing backwardly, then causing the snap between the lateral incisor and the canine. So the etiology, what caused the class 2 skeletal or class 2 malocclusion? So it can be caused by a few factors. So mainly the skeletal, and the other one is dental. So let's look at the skeletal first. Then it can be due to retrognatic mandible, which means the mandible is too short. So this upper or lower jaw or maxilla mandible, they have to in a good proportion. So in their out proportion, then they cause this skeletal discrepancy. It can be the upper maxilla too forward or the mandible too backward. And it can be a combination of both. So for this first picture, you can see there's retrognatic mandible, which means the mandible is too short. So if you cover the mandible, you look at the maxilla, they're quite normal. That's how we assess the patient's skeletal pattern. So you cover either the top jaw or the bottom jaw, then you compare to the whole facial structures, then you know whether they're normal or abnormal. So for this first picture, then you cover the bottom face or the bottom mandible, then you look at the upper jaw, they are quite normal length, then the lip is quite nice. Then this one usually due to the retrognatic mandible. So on the second picture, this one is prognatic maxilla. It means the maxilla is too forward, maxilla is too long. So same thing, if you cover the top jaw or the maxilla, look at the mandible, they're quite normal. It's the maxilla stick up too much. Or sometimes it can be a bit of both combination. So it can be the maxilla too forward or the mandible too backward, combination of both. So they are not really that simple. So most of the time, patients have this combination of the upper maxilla too forward and the mandible too backward. Then the other one, we call it vertical skeletal pattern discrepancy. So I think everyone try this exercise at home. Then if you try to open your mouth now, then try a little bit, open your mandible, or then open your mouth a little bit. Then you will notice your mandible will rotate backward. Then make yourself more class 2. So you look at the mirror from the side. If you open your mouth, then your mandible will rotate backward and make you more class 2. So if a class 3 patient, if you open the mouth, then it make it less class 3. If a class 1 patient, you open your mouth, you make yourself more class 2. If a class 2 patient, you open your mouth, rotate your mandible backward, and make it more class 2 or severe class 2. So vertical skeletal pattern, posterior groove rotation, means the rotation, mandible rotate backward, and make the patient more class 2. So this picture is just summarize what we say just now. If the mandible rotate backward, then the patient will become more class 2. It will increase the overjet. Then you make your FMPA or frontomandibular plane or maxillary mandibular plane stiffer. So they are more than average. The average about 27 if you go through the calf tracing. Then if more than 27 degrees, then you consider more than average. So we come to the dental factor. Just now we talked about skeletal. It can be a mandible too short or the maxilla too long. So it can become due to this dental factor. So dental factor can be due to this space discrepancy, then the crowding in the lower arch. So if you're crowding on the lower arch and sometimes spacing on the upper arch, which means the upper teeth will stick out on the top, then the bottom teeth will lean back because there's more crowding on the bottom, the top will have more spacing. So these are usually due to the rib trap, the lower rib trap behind the upper teeth. They're pushing everything forward, then they're pushing the bottom teeth backward, causing the crowding. So there's a typical example for class 2 division 1, which have spacing on top and the crowding at the bottom. So sometimes patients have a skeletal class 1, but because they're due to this lip incompetency, then it causes this class 2 division 1 malocclusion. So soft tissue factor, like I mentioned just now, potentially competent lips, then pocket upper incisor. So the upper incisor usually push forward. Then if the patient bring the lower jaw forward, they can usually achieve the good lip seal. So incompetent lip, then usually if the class 2 skeletal is too severe, I mean the lip can trap behind the upper teeth. This is due to usually the lower mandible is too short or the upper maxilla is too forward. So sometimes patients try to achieve the anterior ossal seal by doing a few act or few method. So this class 2 division 1 or skeletal 2, they usually have difficulty in achieving this order lip seal. So what they're trying to do, they can posture the mandible forward. By bringing the mandible forward, then the lip can cover the top teeth and then bring the lip seal together. So sometimes they can forcefully bring the muscle, they can stretch the muscle a little bit, and circumoral muscle activity for the lip-to-lip seal. So sometimes if they are rest, then the lip is not competent, but they are forcefully or they consciously bring the lip together, they can achieve this oral lip seal. So second method, like I say just now, is pushing the lower jaw forward. By doing that, then the lip can achieve the lip seal. So sometimes if these two methods doesn't work, then the lower lip can draw behind the upper incisor, then they still can achieve what we call the seal, but it's not the lip seal, but they have the seal and the anterior region. So the patient can pronounce certain words by doing that. So if you keep having this lower lip trapped behind the upper incisor, then they make the scenario worse, makes the situation worse by pushing the upper incisor forward, causing spacing. So sometimes the tongue thrust between the incisor, the contact with the lower lip, which is called adaptive tongue behavior or reverse swallowing pattern. And this one also can achieve the seal and the anterior. And it can be a combination of all these methods, and patient can achieve the oral seal and the anterior. So why is so important to achieve the anterior oral seal? That's because when you want to suck something like milk, or you want to speak or pronounce certain words, you need this anterior oral seal. So habit also can cause this class 2 malocclusion. So if you have a tongue sucking habit or biting or sucking this pacifier, you can push the upper teeth forward, or sometimes you're not careful, you achieve you cause this anterior open bite. Because if you keep putting something between the upper and lower incisor, in long term, it causes this open bite. So the severity of malocclusion depends on the frequency, intensity, and duration of habit. The more you put something in between the teeth, then the more severe the class 2 malocclusion is going to be. Then position digit sucking habit causes procrustation of the upper incisor. So you look at this picture on the left, you put something inside the mouth between the top and bottom teeth, then it makes sense to push the upper teeth forward and the lower teeth backward. Then I say if you put it long enough, then it may cause what we call the anterior open bite. Or sometimes they are not symmetrical. If you have a right-handed, then you put the right thumb more to the right side, then they cause the anterior open bite on the right side. You put in the middle, they cause anterior open bite in the middle. They cause, if you're left-handed, they put it on the left side. It causes more anterior open bite on the left side. So sometimes you can see the open bite pattern, then you know whether they're sucking the left or the right thumb. But the best is stop this thumb sucking or digit sucking habit before it's too late. So usually before the central incisor, the upper or lower permanent central incisor erupted, then this effect is usually temporary. But if you leave it or you delay stopping this habit until the permanent incisor erupted, then usually this open bite can be permanent. So if you have any cousin or any brother or sister kid having this problem or this habit, then you better ask them to stop before it's too late. So this thumb sucking habit also causes retrogressions, pushing the lower incisor backward, incomplete overbite, and sometimes localized, like I say, either the left side or the right side anterior open bite. Then they also cause a narrowing of the upper arch due to the lower position of the tongue and negative pressure generated. So if you're taking shower or you are free, then you have a clean tongue, then you try to put your tongue in your mouth, then you try to suck using your buccinator, then you'll feel the pressure from the buccinator pushing the upper teeth inward. So you push the tongue downward, then the tongue is not feeling the space on the upper, then this buccinator will cause a narrowing of the upper jaw. Then you create what we call the crossbite on the posterior segment. It can be unilateral, then it can be bilateral. It depends the force generated by the buccinator. So really, if you have tongue in the lower position, then usually it will cause a narrowing of the upper jaw. So the natal factor, this one is not very usual, not very common, and sometimes improper delivery of the baby or improper forceps application during delivery can lead to this condylar damage and cause an internal hemorrhage then into the joint area. So whatever causes the trauma to the joint, when the joint recovers, it might become ankylosed or fibrosed, then leading to this underdeveloped mandible. So sometimes if you traumatize the left side, and it can cause asymmetrical jaw. The jaw can develop normal on one side, then ankylosed on one side, then which cause the mandible deviated to one side. So this one not very common, but some people, if you notice, they have asymmetrical jaw. Sometimes can be due to the trauma on one side, damage to the joint. So what is the occlusive features? It can be the angle class 2 molar relationship, and increased overjet, which is a British Standard Institute Incisor Classification, increased overjet, class 2 division 1, then procline incisor, or sometimes it can be just upright, sometimes it can be procline, then usually procline incisor, they are spacing, then upright, then sometimes it can be normal, provided the skeletal discrepancy is not too bad. Then have an increased overjet, maybe complete or incomplete. Then usually if they are not complete, then they have a reduced or average overjet. If they increase, then usually have deep bite or increased overbite. And it can be incompetent lips, habitually apart at rest, cause the drying of the anterior gingiva. It's not only the drying of the anterior gingiva, then most of the time they dry the lip also. Because if you have a lip incompetency, then a lot of people, they tend to prefer your mouth rather than the nose. Then it causes dryness to your lips. Then sometimes you're not careful, the lip can crack and cause a bleeding. So you look careful, you pay attention or look carefully, then you pick up all these signs and symptoms from the patients. So how are you going to assess the patients? So usually before you do any auto treatment, so the patient assessment is the most important thing. So you have to do the proper assessment before you come out with the proper diagnosis. So first is the patient age, then the further growth expected if favorable. So we do this what we call the visual treatment objective Then you try to ask the patient to bring the lower jaw forward. Then if the position the lower jaw forward, then they end up with what called a nice facial profile. Then this one is usually favorable treatment outcome. So if you want to assess the patient, whether they're suitable for the auto treatment, and usually ask patient to bring the lower jaw forward, then achieving what we call the oral seal or lip competency. And if they have a nice profile, then most probably they end up with a good result. Then vertical skeletal growth and posterior growth rotation, the prognosis. So like I said before, if you try at home now, you try to open your mouth a little bit, then the jaw will rotate backward, then it make this class 2 more severe, or you become more class 2 skeletal. So if this patient have this what called a backward rotation or posterior growth rotation, then usually their prognosis, they become more class 2 with time. And the third one is the lack of growth, so limit treatment by orthodontic means. So if they are not growing anymore, they are adult patient, and there's very limit how much we can do for orthodontic treatment, then usually end up what we call the extraction, usually extraction of the upper four, doing the push upper incisor backward. So if they are still growing, there's so many things we can do. We can do this growth modification treatment using a myofunctional or the twin block, or sometimes what we call the headgear, to modify the growth pattern. So skeletal pattern, then you assess the patient anterior and posteriorly. Those mainly you look at the upper jaw and the lower jaw, like I showed you in the picture just now. You can cover the top jaw, the bottom jaw. You can assess whether they are assess growth in the maxilla or mandible. Then vertical skeletal discrepancy, you look at the facial height. So for the facial height, usually divided into upper, middle, and lower. So the upper usually the forehead, then the middle is the maxilla, then the lower facial height is the mandible, below the nose, then to the mandible. So if you look the patient from the front, then you can divide the face into 3 parts. That's how you assess the vertical height or the vertical skeletal discrepancy. So if they're anterior growth rotation, then mostly they end up less class 2 with time. I say if you open the mouth, then the backward rotation, they'll cause it more class 2. So if the patient have the posterior growth rotation, then this patient mostly end up in more severe class 2 with time. So soft tissue pattern, very simple. When the patient walk in the clinic, then when they are in the rest position or they are relaxing, then you look at the lip, whether they're competent or not. But most of the time, when you ask the patient, try to relax, then they're not relaxed. So the best time to assess the lip competency is when they just walk in the clinic. So once you start looking at the lips or the face, then they become nervous, then they tend to bring the lip together. Then it's difficult for you to assess the lip competency. So you have to identify the etiology. If it's a persistent habit, then you're trying to correct it first. Like say, if you have thumb sucking habit, you have to stop it early before the effect becomes permanent. So the lower lip trapped with potential competent lip, corrected with the retraction of the upper incisor within the lower lip. So let's say they can bring the lip together if they want to. I mean, they are consciously bringing the lower lip together. They can achieve the oral or the good lip seal. It means that the lip trapped behind the upper incisor slightly. So you can retract the upper incisor by closing the front gap. Then usually they help the patient achieve a better lip competency. Increase vertical skeletal pattern proportion with incompetent lip pro-stability following treatment. Yeah, this one we keep repeating this. If you have backward rotation, then means they have become more class 2 with time. Then this kind of patient, usually the treatment is not stable. So they have a poor prognosis. So the ideal position at the end of treatment, so we are trying to achieve what we call the stable position of the upper incisor, and so that the lower lip can rest on the upper incisor 1/3. So you can see this picture. If the lower lip trapped behind the upper incisor, that will make the patient more class 2 with time, or you can open up the upper incisor gap. So the best one is you can bring the upper incisor back, then so that the lower lip can close on the upper incisor, then they will maintain the result. If after you close the gap or you bring the upper incisor backward, you cannot achieve what we call the lower lip cover the upper incisor, then the result usually not stable, because without the lower lip, the upper incisor still can come forward. That make the treatment less stable. So if your lower lip can cover the upper incisor, then the treatment usually more stable. So facial appearance, considering facial profile for type of treatment, functional appliance versus headgear. So like we said before, the the class 2 malocclusion can be caused by skeletal. Then skeletal is divided into upper maxilla and lower mandible. It can be the upper maxilla too forward or too long, or the mandible too short. So if the mandible too short, then usually we do what we call a functional appliance, try to bring the lower jaw forward. Then if you have upper maxilla is too long or excessive growth, then we use what we call the headgear, try to restrict the upper maxilla from growing forward. So there are different types of treatment. If you're too short, you make it too longer. If you're too long, then try to make it shorter. So as simple as that. So surgical approach preferred in some cases, such as obtuse nasolabial angle and excessive incisor show. So sometimes if the patient have a severe gummy smile, or sometimes the skeletal pattern become too severe, that means the lower jaw is too short, beyond the scope of braces, we cannot do braces only to achieve the best result. Then this kind of patient usually best to deal with surgical approach. Maybe we have to cut the lower jaw, or sometimes we break upper and lower jaw and realign the upper and lower jaw back to a better proportion. So these are what we call the orthodontic surgery, usually best for the severe skeletal 2 patient. So patient profile is one of the criteria influencing the decision of extraction. So sometimes if the class 2 division 1, when you look at the lip profile or the facial profile, let's say if you look at the left picture, this patient have a protrusive lip, means the upper and lower lip, they are sticking up too much. Then usually we end up taking out some premolar, then pushing the upper lower incisor backward. By doing that, the lip also will fall back, then it'll keep you a straighter profile. So you look at the picture on the right side, same thing. You see the upper lip, they are protrusive. Then we take out upper incisor, then push it back. Then when the teeth fall back, then the lip also will fall back. It end up a better or straighter profile. That's how we do braces, then achieve a better facial profile. So now we come to treatment planning. After you assess the patient accordingly, then you come up with a treatment diagnosis, which is class 2 division 1, either due to the skeletal, lip profile, skeletal, the lip, or the dental factor. Then after that, you come up with a treatment plan. So for this class 2 division 1 with a mild class 2 or class 1 skeletal pattern, so mainly due to the upper incisor sticking out for client. So you can use a removable appliance with the class 1 skeletal pattern and only tip the teeth back. By tipping the teeth back, then we can get a better oral seal, or the anterior lip can be a bit more competent. Then usually the result be stable. If not, then you can use a fixed appliance with extraction for bodily movement. Let's say you want to move the teeth back so much, then you need to take out the premolar, then it's best to deal with the fixed braces. So what happened to this class 2 division with the moderate class 2 skeletal pattern? So just now we talked about the class 1 or mild class 2 skeletal pattern, but when it comes to moderate class 2 skeletal pattern, usually we have to do the braces plus the extraction. So which it means the fixed braces will come in for this kind of cases. So of course you can do orthodontic camouflage by correcting the overbite before the overjet. So if you use your this one, I can't open the camera. Okay, look at the picture on the right side. So if a deep overbite, then you make your top teeth cannot come back because the bottom teeth is preventing the top teeth from coming back if you have deep bite. So the lower teeth is blocking the top teeth from coming back. That's the reason why you have to correct the overbite for the overjet. It means you open the overbite, make it normal, then you got a space to push the upper incisor backward. That's how we do the braces. So you have an overbite issue, always settle the overbite first before the overjet. So if you keep pushing without opening the bite, then the top and bottom teeth will go back together. So they end up still increase overjet. So this is very important concept. You have to open the bite. The deep bite have to settle first before you start tackle this overjet issue. So overbite correction requires space in lower arch. If extraction required in the lower corresponding teeth in the upper is removed. So a lot of time you have to balance. You have to balance extraction. So imagine you have an uneven number. So let's say you have a lesser number T on the top, then it become class 3. If a lesser T at the bottom, it become class 2, more class 2. So a lot of time for braces purpose, we always balance it with the top and bottom T extraction. So a lot of people, they end up 4 premolar extraction, 2 top, 2 bottom, or each on every quadrant. That's the reason why we have to balance the number, so we can get the even number on top and bottom, then the bite will be nicer. So class 2 division 1 without align lower arch. Okay, distalization of the upper buccal segment with headgear if a molar relationship is husky class 2. Sometimes they're just slightly class 2, it means the molar is only half unit, or sometimes quarter class 2, angle class 2. So you can use a headgear to distalize the buccal segment. So if you know what is headgear, they use the skeletal or the skull as ankle, putting a cap or the strap, then attached to the intraoral appliance, which can be removable or fixed. Then using this cap or your skull as an ankle, then attach the elastic, then hopefully you can push everything backward. So this is how you call it extraoral ankle correction. So orthodontic camouflage, then it can be body retraction of the incisor based on availability of palatal, cortical bone, and patient profile. So this means you have to push the upper incisor backward. You have to make sure everything, the bone is thick enough. Because if you move the incisor backward, there's no bone, then end up the tooth might be coming out from the bone or the teeth. So before you do this incisor retraction, we always end up taking out what we call the calf X-ray. Calf X-ray is a caphometric X-ray, then assess the patient's skeletal pattern and the incisor angle. So if the incisor is very proclined, you can retrocline the incisor quite a bit or pushing the teeth backward quite a bit. But if the tooth is already quite upright, then there's how much, or there's a limit how much you can push the upper incisor backward. Okay, for this example, you can look at the picture. The upper incisor is so proclined. So this end up taking out 2 upper premolar, then we're getting about 7 millimeter space on each side. Then by using this gap or space, you can push the upper incisor backward quite a bit. By doing that, then you achieve what we call the class 1 incisor relationship. Same thing, huh? This one also procline upper incisor, then lower a bit procline. So we end up taking out 2 top, 2 bottom again. So premolar is always the choice for extraction. But sometimes we come to compromise, which you have a few or heavily filled molar, then we end up taking the molar rather than the premolar. But ideally, all the braces patients, we usually go for premolar extraction, provided everything is in good condition. So if you take out 4 premolar or sometimes 2, sometimes 4, then after 2 years of braces or fixed braces treatment, then usually end up with what we call the nice class 1 result. But you have to sacrifice 4 good teeth in order to get the result. Sometimes worth it or not, you have to consider very carefully. If the patient prefer not to take out any teeth, then this result cannot be achieved. So just now we talked about the mild, moderate. Now we come to severe class 2. Severe class 2 usually caused by skeletal. So it means the upper jaw is sticking out too much or the lower jaw is too short. So sometimes you can do some early treatment to reduce the severity of this class 2 skeletal. So prominent incisor was susceptibility to trauma. Like say if the upper incisor is stick out too much, then every time you hit something, or you're playing games or hit by the baseball bat, the first one to be injured is the upper incisor because they're sticking out too much. So most of these severe class 2 patients, they usually have the chipped incisor due to trauma. And sometimes it causes aesthetic concern because they are sticking out too much. Then they're teased by the friends or classmates. Then this kind of patient usually have to start early. First, to reduce the trauma risk. Then second is to improve the aesthetic. then so that patient have the better self-esteem. So if the patient keep having this low esteem, then it can affect their self-confidence. So that affect the study also. So braces not only improve the aesthetic result, at the same time they improve the patient confidence. So then patient can perform better in school or study. So there's so many research done on the psychology part of the patients. So you can look at those research if you're interested. So for patients have the upper teeth sticking out too much, we always try to start early for the patients good for the psychology aspect and the trauma risk. So factor to be considered during early treatment, usually they have incompetent lip in growing children, reduce the stability, require prolonged retention. So if you start too early, sometimes the result not stable because the lip is not fully grown. So even though you reduce the overjet, then if the, like I said, the lower lip is not covering the upper teeth, then the result can be not stable. Some space consideration limit the complete reduction of the overjet. So sometimes patients have the median diastema. It's very common during the early ducting stage. Then if you close all the gap, then that's the best overjet you can get. And retraction of the upper incisor before the canine eruption, the risk of the root resorption or diffraction. So you remember, if you start early, the canine is not erupted yet. So if you push all the incisor backward, it might hit on the canine, which cause the resorption of the lateral incisor root. Because when everything, two objects hit on each other, either one will give away. So for this case, then the incisor usually is a weaker one compared to the canine, and the incisor usually the root will resorb. Then further treatment often required in permanent dentition. So this one you have to think carefully. A lot of time we start early, then patients they end up what we call the fixed braces lethal. So sometimes the mom or the parents, they are not understandable, then they can be angry because they spend so much of time and money for the first stage, and they end up what we call the second stage, where they pay more for the fixed braces. So they explain to the mom, the first stage is mainly just to deal with the overjet, and the second stage is mainly deal with the crowding and the spacing. So even though you start early, it doesn't mean you can avoid the treatment later. But if you start early, usually they reduce the complexity and severity of treatment, which make your second stage much easier. So for example, this patient has the increased overjet and lower lip trap behind the upper teeth, which push the upper teeth forward a lot and causing the spacing. Then we can use what we call a functional twin block. Functional twin block appliance. They are very simple. They are one block on the top and one block on the bottom. So every time patient bite together, it tends to posture the lower jaw forward. By pushing the lower jaw forward, you stretch your muscle. The muscle is a masseter. Then this muscle is going to do the job for us by bringing the upper teeth backward and the lower teeth forward. So by wearing this functional or twin block for about a year, then usually you can push the upper teeth backward quite a bit, then bringing the lower teeth forward also. So at the end of the result, patient is going to have a normal overjet. So like I say, the first stage, the purpose is to bring the upper teeth backward, reduce the overjet, or sometimes the overbite also. So this functional appliance can be quite powerful. Sometimes they change the skeletal pattern. So you can see from the far left pictures, this patient has the class 2, maybe moderate class 2, if you agree with me. Then after the treatment, the patient ends up what we call the class 1 or maybe slightly mild class 2 skeletal pattern. So this one only can achieve when the patient is still growing. So that's the reason why functional or myofunctional braces always start during the patient pre-puberty growth spurt. So surgical correction usually for adult or non-growing patient, or they are too severe class 2. So adult with the skeletal discrepancy beyond the limit of camouflage, means braces cannot achieve the best result. So this kind of case, then usually they need what we call surgical approach. Then either the maxillary setback or mandible advancement. Either you cut the upper jaw and push it back, or you cut the lower jaw and bring it forward. Sometimes it can be a combination of both. You cut the upper and lower jaw, like I say, rearrange it to the better proportion. So can be single jaw, can be double jaw. So this one usually the orthodontist will discuss with the oral surgeon, then we come up with the best plan for the patient. So of course single jaw will be cheaper, double jaw will be more expensive. So you want to know the price, if you do it in private, double jaw will easily cost you 40,000 to 50,000. If you do in government, maybe they charge the screw and plate only, then the surgery is usually free, then they will cost you about 6,000 to 7,000 for the material cost. If you go for a semi-government, which is university-based, UKM, UM, then it costs you about 20,000, which is half of the private hospital fees. So second is gummy smile due to increase of vertical height or the short upper lip, worse with the incisor retraction. So if you take out the premolar, you retract the incisor backward, you make the gummy smile worse. What's the reason behind it? Because when you smile, you cannot bring the upper lip upward when the incisor is porcine. So if you bring the incisor backward, then usually the muscle can push and can pull the upper lip upward a bit more than before. That's why if you do the upper incisor retraction, then gummy smile will be worse because you can pull the upper lip upward a bit more than before. The hypo headgear in growing patient but requires surgery and adult. So hypo headgear, it can restrict the upper incisor from growing forward, but sometimes the surgery will be a better option for the non-growing patient, adult. So look at this picture on the bottom left. This one is just a picture showing that this is what we call a mandibular advancement surgery, single jaw. So look at the right picture. This patient have a short lower jaw, retrusive mandible. Then after the surgery, they'll look quite straight profile because they'll bring the lower jaw back forward by doing this advancement surgery. So this chart is just summarize what I say just now. For teenagers or growing patient, then the option will be more compared to adult. So adult, if you're severe class 2, most of the time you end up extraction or sometimes even surgery if that's too severe. But if you're a teenager, then if you are mild to moderate and severe cases, then mild cases, sometimes you can just deal with the fixed braces when they are 12 or above 12 years old, when all the permanent adult is established. Or sometimes they're moderate to severe case, they can start what we call a functional appliance to reduce the severity, bringing upper incisor backward, reduce the overjet. Then after that, you deal with the fixed braces later. But if you come to severe case, sometimes even for teenager, you can't do much. You wait until they become adult, then you do the jaw surgery later. Okay. I think we finished the class 2 division 1 malocclusion. Then the class 2 division 2 we will deal with the next lecture. Do you have any question to ask me regarding this class 2 division 1? Any question? Are you all still there?
Doctor?
Okay. All right.
Repeat in class 2 division 1 with moderate class 2 skeletal.
Okay.
There's one part where you said overbite correction requires space below arch. And can you explain the extraction part again?
Why we have to extract the upper if you extract the lower?
Yeah.
Okay. So very simple. Show you some example. See. Okay. So you look at these pictures. This one is a calf X-ray tracing for one patient. Have a class 2 division 1 malocclusion. So let's say if the lower incisors stick out too much, then you have an increased overjet and overbite. And if you take out the lower, and the top teeth will stick out still. That's why you have to balance with top and bottom extraction. So mostly, if we do the upper or lower extraction, most of the time you have to balance with the upper extraction. Like say if you have an uneven number, then either the T will become class 2 or class 3. So if you take out just the top one, then it becomes class 3. If you take out the bottom one, it becomes more class 2. So most of the time you have to balance it before extraction, 2 top, 2 bottom. Then if you're curious why we have to reduce the overjet before, reduce overbite before the overjet. Okay. All right. Look at this X-ray. Look at this X-ray. This patient is typical class 2 division 1 with the increased overbite. So if you keep pushing this over to upper incisor backward without reducing the overbite, then you're pushing the top and bottom teeth backward together. You're not achieving anything, but mainly pushing everything backward. That's why you have to open the bite and give the space between the upper and lower teeth before you push the upper teeth backward. Hope that answers your questions.
Yeah, thank you.
Okay. Any more questions? If not, then maybe we'll go through one case.
We have one more question.
Oh.
Can you explain half class 2 unit?
Half class 2 unit. What you want to explain? You mean treatment plan or diagnosis or classification? Class 2 half unit. What you want to ask?
The concept.
The concept? Are you clear about the classification, class 2 half unit? What is class 2 half unit? Tell me about it. What is class 2 half unit? Classification, what's class 2 half unit? Can you tell me what's class 2 half unit? Okay. So you look at this picture. Can someone tell me what's the classification of this? The top picture. Can you see the picture?
This is class 2 division 1.
I know it's class 2 division 1, but I don't want the incisor. Tell me the molar relationship. So just now you mentioned about class 2 half unit. Half unit usually is a classification for molar relationship. Then we can go for quarter unit, half unit, or full unit. So what's the unit mean? So what's half unit? What's quarter unit? What's full unit?
Is it the amount of the tooth, like either move forward or move backwards?
Almost partially right. So if you look at the unit, unit means that cups. Every cups means 1 unit. You look at the molar, they have 2 units, the mesial and the distal cups. So when 1 unit, same for the bottom, there are half unit and full unit. So if you go for partial or half unit, mean this cups, it's just the lower cups. Cup to cup is called class 2 half unit. How should I demonstrate to you? See, Cheers. Okay, so for this picture, you look at the top picture. So you see the mesial cups is occurred in the interdental space between the 5 and 6 of the lower. This one called full unit. Because the molar mesial buccal cups is occurred anterior, or they wedge between the interdental space. This one I call it full unit. And the bottom right, on the bottom picture, you see this one almost cups to cups, upper and lower. This one called half unit. So like I say, you divide the molar cups into 2 units. Then the first unit is the front, then the second unit at the back. So this one, if you come forward, just half of the cups, then you consider half unit. If they come forward to the full cups, then this one is called it full unit. If the quarter, it means it's just 1/4 of the mesial buccal cups. Does it explain?
Yeah, thank you.
Okay, so if you come to half unit, just like you ask, okay, we talk about classification of the half unit, then how we deal with this half unit. So you see the half unit is less severe compared to the full unit. So half unit will say the mild to moderate class 2 usually. Then this one you can deal with what we call the extraction plus the fixed braces or camouflage treatment. Or sometimes if the patient is young enough, then you can do what we call the functional, or sometimes you can do the headgear. Depends whether they're mandible or maxillary access. So when it comes to full unit usually means severe class 2, and sometimes you have to deal with the surgical approach, which means orthodontic surgery. Answer your questions?
Yeah.
Okay, let me see. I can find a pictures showing the class 2. Okay. Okay. So tell me what classification it is, the molar. On the right, top right, top left pictures means the right quadrant. So this one.
Class 1 half.
Class
Sorry,
one.
class 2 half unit.
Yeah, it's almost class 2 half unit or quarters. This one class 2. So maybe we'll go to the other one. Class 1. Okay, how about this? What classification is that?
Full unit.
Yeah, it's almost full unit or what we call the 3/4. So you're very precise. Sometimes you divide the cuffs into four portions, and sometimes you just want to be not too precise and divide the cuffs into half. So either half unit, full unit, or sometimes very precise, you call it 3/4 or quarter unit. So for this patient, let's say this patient is not functional, then the increased overjet can be reduced for the first phase. Then you can see this one, the middle, bottom. Then this one is achieved by the functional or the twin block. But I look at the teeth, they're still crooked at the front. Then the spacing on the top is still there a little bit. And the lateral bite is not perfect. So this one usually followed by what we call the fixed braces, second stage, and the final detailing of all the occlusion and position of the teeth. So if you start functional, it just reduces the overjet. It doesn't solve your crowding problem most of the time. So you have to deal with the fixed braces later. Any questions? No questions? So no question, then maybe we go back the outcome. Okay, all right. Then maybe someone can explain to me the classifications of this class 2 division 1. What's the class 2 division 1 means? Anyone?
The maxilla is more protruded and the incisors are more proclined.
Okay, what exactly? Tell me what's the definition of this class 2 division 1 according to this British Standard Institute. What's the definition of class 2 division 1? So class 2 division 1, it just means the upper incisor are occurred behind this cingulum plateau. This cingulum plateau, it means the middle third of this palatal surface. So class 2 division, it just means it biting behind. See the incisor, lower incisor biting behind the surface, biting belly surface. But class 2 tip 1 means the upper incisor, either the procline or in the normal angulation. Okay. Can someone tell me the etiology of class 2 division 1? Just name the factor involved. Etiology. It can be skeletal. It can be dental. It can be due to habit. Okay, what's the skeletal? Can someone tell me the skeletal? What's the ecology part for the skeletal factor?
Retrognatic mandible.
Yeah, retrognatic.
Retrognatic.
Yeah, good. Either the upper maxilla too forward or too long, or either the lower mandible is too short. Very simple. Then how about the dental factor? So what causes the cluster division 1? Can be due to the upper spacing and lower crowding. When we're crowding, it go back. The spacing, it go forward. Then it can be due to the lower incisor. The lower lip trap behind the upper incisor. Soft tissue factor and pushing the upper incisor forward. And the last one can be due to thumb sucking habit. Okay, discuss the criteria of patient assessment. How are you going to assess the patient for cluster division 1? So first, you look at the patient, lip competency. And second, you look at the patient's skeletal pattern, anterior, posterior, and vertical in 3D dimension. Okay. Then you look at the habit also, whether they have a thumb sucking habit. Explain the clinical features of cluster division 1. This one we already did. Explain the treatment planning. Okay, can someone tell me how we're going to plan the case for cluster division 1? So we subdivide into 3, mild, moderate, and severe skeletal or severe cluster division 1. How are we going to plan the case? So if the patient is still growing, then maybe you can start what we call a functional to push the upper incisor back. Then if they are already late, they're not growing, adult patient, mostly they end up what we call the surgery treatment for severe class 2. But if you do this mild to moderate class 2, then usually you can deal with what we call the fixed braces plus extraction most of the time. I think that summarizes the treatment planning for class 2 division 2. So I think we finished the lecture today. Do you have any questions to ask me before we end this lecture? If not, then I think I'll end this lecture. Don't forget your sign attendance. Then I'll see you soon for the part 2. Okay?
Thank you, Doctor.
Okay.
Thank you, Doctor.
Bye. Stay safe.
Thank you, Doctor.